Today we are going to learn about anti-arrhythmatic drugs. These are the group of pharmaceuticals that are used to suppress abnormal rhythms of the heart. Classification of anti-arrhythmatic drugs are done by Singh Vaughan Williams classification. It classifies the drugs classes into class 1, 2, 3 and 4. Class 1 is divided into class 1A, 1B, 1C. First of all, class 1 drug. They are the sodium channel blockades, reduce phase 0 slope and peak of action potential. Class 1A are moderate blockades. They moderately reduct the phase 0 slope and increase action potential duration and increase effective refractory period. Class 1B drugs are weak and small reduction in phase 0 slope, reduce action potential duration and decrease effective refractory period. Class 1C, they are strong, pronounced reduction in phase 0 slope, no effect on action potential duration or effective refractory period. Class 1A drugs include quinidine, procainamide, disopyramide. These are rate-dependent block of sodium plus conductance, intermediate kinetics between 1B and 1C. Prolong cardiac action potential. Next, class 1B drugs. This drug include lidocaine, mexiletine. Rapid dissociation from sodium plus channel. These are useful in ventricular tachydysrhythmias. 1B drugs include lidocaine and mexiletine. Lidocaine is important in the treatment of ventricular tachycardia and fibrillation, often as an adjunct to DC cardioversion. An effective plasma concentration is rapidly achieved by giving a bolus intravenously. For lidocaine, an effective plasma concentration is rapidly achieved by giving a bolus intravenously, followed by a constant rate of infusion. Mechanism of action of lidocaine. Lidocaine is a class 1B agent that blocks sodium plus channels. They reduce the rate of increase of cardiac action potential. They increase the effective refractory period. Now, it selectively blocks open or inactivated channels. Dissociates rapidly. Adverse effects of lidocaine. In the central nervous system, it causes drowsiness, twitching, paresthesia, nausea and vomiting, focal seizures followed by generalized seizures. In the cardiovascular system, lidocaine causes bradycardia, cardiac depression due to negative inotropic effect and asystole. Pharmacokinetics of lidocaine. Oral bioavailability is poor because of pre-systemic metabolism. Given IV intravenously, metabolized in the liver, clearance being limited by hepatic blood flow. Heart failure reduces lidocaine clearance, predisposing to toxicity unless the dose is reduced. The difference between the therapeutic and toxic plasma concentration is small. Monoethyl glycyl silidide and glycyl silidide are active metabolites, have less antidysrhythmic action than lidocaine, but with central nervous system toxicity. The mean half-life of lidocaine is approximately 2 hours in healthy subjects. Drug interactions. Negative inotropes reduce lidocaine clearance by reducing hepatic blood flow, consequently predisposed to accumulation and toxicity. Class 1C. These include flecainide, propafenone, slow dissociation from sodium plus channel, prolonged His-Purkinje conduction. Side effects: nausea, dizziness, and blurred vision. Class 2 drugs. They are beta-adrenoreceptor antagonist. Anti-arrhythmatic properties of beta-adrenoreceptor antagonist are useful in the following clinical situations. Patients who have survived myocardial infarction, irrespective of any ECG evidence of dysrhythmia. Beta-adrenoreceptor antagonists prolong life in this situation. Second one, inappropriate sinus tachycardia in association with panic attacks. Third one, paroxysmal supraventricular tachycardia that are precipitated by emotion of exercise. Fourth one, rapid atrial fibrillation that is inadequately controlled by digoxin. Fifth one, tachydysrhythmias of thyrotoxicosis. Sixth one, tachydysrhythmias of pheochromocytoma after adequate alpha receptor blockade. Atenolol, metoprolol, esmolol, propranolol. These are the examples. Atenolol is available for intravenous use after myocardial infarction. Esmolol is a cardioselective beta-adrenoreceptor antagonist for intravenous use with a short duration of action. Its elimination half-life is approximately 10 minutes. Beta-adrenoreceptor antagonists are given more commonly by mouth when used for the above indication. Contraindications and cautions. Contraindications include the following: asthma, chronic obstructive pulmonary disease, COPD, peripheral vascular disease, Raynaud phenomenon, uncompensated heart failure. Beta blockers are actually beneficial in stable patients but have to be introduced cautiously. Drug interactions. Beta blockers inhibit drug metabolism indirectly by decreasing the hepatic blood flow secondary to decreased cardiac output. This causes accumulation of drugs such as lidocaine that have high hepatic extraction ratio that their clearance reflects hepatic blood flow. Increased negative inotropic effects with verapamil if given intravenously. This can be fatal. Lidocaine, disoprolol or other negative inotropes exaggerated and prolonged hypoglycemia occurs with insulin and oral hypoglycemic drugs.